Produced. We're good. All right. So excited to have Brian Courtney here today to talk about a very important topic.
Yep.
Self-funding health insurance, a cost a lot of you probably are dealing with your businesses. He's going to talk about some ways you can help manage that.
Lower
Brian,
costs. That's right.
Floor is yours.
All right. Thank you. So I'd like to start this presentation. Number one, I'm excited to talk to you guys about it today. It's a little bit of an echo here. I don't know if that, can you guys hear me okay?
I think we got it.
Got it. All right. So is this working? So before I start this presentation, I had a request from my good friend Doug here, because I said, I'm going to give this presentation on healthcare self-funding. He was very interested in it. And he said, are you going to make insurance great again? I sure am. It's going to be huge. All right. The hair piece is not included with the hat, but you guys are all going to be part of the MIGA movement today. So MIGA. So when we deliver fully insured renewals, this is typically the face that we see across the table because costs continue to go up in fully insured. The client in front of us has no real idea of why that is because there's no transparency with respects to claims. And it's just a completely frustrating process. But fortunately, there are a number of ways that you can transition from a fully insured program to a self-funded program. And we're going to talk about that today. But first, we're going to talk about what's driving healthcare costs, because there's a lot of things that are driving healthcare costs. We're going to talk about the growth in the self-funding market, and then we're going to compare self-insured to fully insured. Then we're going to talk about the different group self-funding models that are available and how they work and how they manage the claims process. But the most important thing is in the risk management strategies. The funding structure is important. It's a good first step to managing claims, but you want to develop cost containment strategies to make sure that you're maximizing the self-funding platform that you chose. So costs are rising. Why are they rising? Most of it is in pharmacy. And as you can see here, these are the best-selling drugs in 2024. And those numbers are in the billions of dollars, So there's been an increased rise in specialty drugs, a lot of it GLP-1 drugs, the weight loss drugs, the diabetes drugs. In addition to that, with the ACA, Obamacare, they removed lifetime caps. And since then, it's allowed gene therapy and cancer treatment to take off. So we're seeing an increase in $1 million claims. Now we're seeing more $2 million claims. Also, vertical integration. This is where one entity owns multiple entities within the healthcare vertical. And I'll talk a little bit about that next. And then the medical loss ratio. So vertical integration is where a healthcare has a single entity organization that controls various levels of delivery and payment. That's like a physician group is owned by a hospital. An insurance company owns their pharmacy benefit manager. And it is now leading to higher healthcare costs to our plan participants. The next is the medical loss ratio. I'm sorry I'm going fast because I have a lot of slides, but the medical loss ratio was largely applauded when the ACA came out. It said, look, we're going to limit what insurance companies can make on premium. So for every dollar that they collect, they need to spend 85 cents on the dollar on medical costs and healthcare quality improvement, leaving 15% left over. Sounds great, right? We're going to limit how much they make. But newsflash, the insurance industry, they're in the business of making money, right? They want to make money. So what incentive do they have to lower your claims costs? Zero incentive to lower your claims costs. So they want to see your claims costs go up because they know that they can charge higher premiums. And by charging higher premiums, they get a larger profit as a result of it. So again, well-intentioned, but it's had the opposite effect of what you would want to see, right? So this is why we've seen a growth in the self-funding marketplace. And most of your employees within your organization are relatively healthy. About 90% are at that healthy and at risk. So they're getting routine care. They might have the occasional injury from now and then, and they're taking mainly generic prescriptions. But as you can see, they make up only about 20% of your cost. It's the other 10% of your population that are in that chronic to catastrophic. And that's where we're starting to see healthcare costs rise. And this is where claims need to be managed better, because we want to keep our employees in that healthy at-risk stage as best as we possibly can. Yes, you're going to have a catastrophic claim, but a self-funding structure will protect against the catastrophic claims and reward for managing claims costs below the deductible. So this is the healthcare cost increases over the last 25 years. You can see in 1999, about a little over 2,000 for an individual and 5,700 for a family. That's risen now to almost 9,000 for an individual and 25,000 for a family, right? And then again, this is the employer-sponsored coverage. You can see the costs continue to rise on the employer-sponsored coverage. So when I share this slide, it blows people's minds because the fully insured world does not want you to go self-funding, all right? Because you are worth 5 times more the operating profit staying where you are than looking at a self-funded model. So the bottom line is you have little control and there's not much you can do about it by staying in fully insured. So self-funding is a pay-as-you-go model. It's a mechanism where you're covering all covered and medical and pharmacy claims up to a certain level, and then you're transferring risk to a reinsurer that sits excess of your claim fund. And it's no longer for the big guys. So Steve, you asked a question prior to this presentation. It was like, how low can we go? And I'm here to tell you that most companies with 50 insured lives or more are now starting to transition to self-funding, where, Jeff, you know this pretty well, like 10, 15 years ago, it was like, oh, if you don't have 500 insured lives, there's no way that you can go self-funding. So now it's dipped down to 50 insured lives or more on the plan. More opportunities to pull risk together, yeah. More structures, more platforms to do that. So increased competition and self-funding has really helped. And the best part about it is, you're insuring your risk, or you're having your claims processed with brand names that you know. So IBC, they have independent administrators. That's their third-party administrator of claims. Aetna has Meritain, all right? Cigna has their own TPA as well. So you're still utilizing the network, but you're using a third-party administrator to manage the claims. And this is just a slide that I mentioned too. It's just like you could start to see that this number continues to rise. This slide's a little bit old. I would say that's a lot higher now. So I love this slide. I love this slide. And I'm going to tell you why I love this slide. This slide is completely wrong. Why is it wrong? Yeah. Yeah, so it's a greater risk. We're saying that it's greater risk going to the right versus less risk going to the left, which is fully insured, correct? That's what we're saying? Okay. A couple slides ago, I said, where are healthcare costs going and fully insured? Up. That is not sustainable. It's more risky, in my view, to stay where you are, the status quo, than to try to transition to a self-funded model where you have greater control over your insurance destiny. So I love this slide because I'm like, this slide's completely wrong. We should be telling people it's more risky going this way than going that way, right? But I keep it up there just for a talking point. So when you're in fully insured, you start to see a compounding effect on renewals. So fully insured on the left, self-funded on the right. If you have a bad year in fully insured, they're going to get their pound of flesh at the next renewal. You're going to get a big increase. Now, that next year, that's your floor. You're never going down. So even if you hit them with a good year, you might get a small increase, but you're not going to get a return on premium. Juxtapose that to self-funded, you're going to have 7 out of 10 years are going to be good years, where 2 or 3 of those years are going to be below average or poor years. But accumulating that surplus to your benefit can help pay down healthcare costs. Yes, sir.
So presuming we're fully insured, if we want to switch to self-insured, is there an analysis that's done looking at our plan and premiums over the last 4 to 5 to 10 years about what, if it makes sense to switch to self-insured?
Yeah, so it's more difficult going from fully insured to self-funding in the first year. They try to medically underwrite. Some groups do, some groups don't, but they're trying to match and mirror what you're currently doing now and get a sense of what the claims experience are. A lot of the actuaries that work for these self-funded platforms were former actuaries within the insurance companies. So it depends, but most often you're going to reduce your spend, your healthcare spend, in the administrative costs, which will be in a couple slides next. Great question. So fully insured versus self-funding, control, little control to no control in fully insured versus maintaining your own benefit levels in self-funded. Surplus, you don't get to keep a surplus in fully insured. They keep the surplus, right? You get to keep the surplus in self-funded. Protection, they retrospectively rate you every year. All right, so they take a look at your claims history, regardless of where those claims are going. If they're ongoing claims or they're basically closed claims, they're going to get their pound of flesh on renewal. Self-funding, they're going to take a look at the claims and saying, is this an ongoing issue? And do we need to discount now that this is no longer an issue for the plan sponsor? So an example would be somebody who had a serious medical condition and unfortunately died, but is no longer on the plan. We don't need to price for that going forward. Or it could be a baby that was in the NICU. Those are usually $1 million claims. But the baby's healthy now, doing fine, is out of the NICU. Again, we don't need to price that into our next renewal. Transparency. You have none in fully insured. You do not get claims data to the degree that you should with self-funded. And that's really where self-funding matters, is because you get to look at how your plan is being utilized and you get to change your plan benefits to try to spur better behavior, to reduce costs and get better healthcare outcomes. Without that data, you're kind of flying blind and you really don't know where your costs are going. And then the savings, higher administrative costs and fully insured versus self-funding. Out of the gate, you're going to reduce your administrative costs. Also, there's no immediate savings when you do any type of claims cost reduction. So like when people say, well, you're going to do wellness with fully insured, it might not have an impact, it might not have an impact. And if it does have an impact, you have really no way of knowing whether people are living healthier lives or not. Where in fully insured, in self-funding, you definitely have access to that. And then high and unstable renewals in fully insured. We've seen anything from like 60 to 70% increases in fully insured without claims data. So when we sit across this table and we're like, well, you're going to see a 60% increase. Well, why is that? Oh, I don't get the claims data either as the broker. So that makes a really frustrating insurance purchase. That's not true in self-funding. So in fully insured, you have all costs are fixed. There are no variable costs. Underwriting profits, they go to the carrier. So they have a claims fund, right? They have a claims fund, and then they have an administrative fund that sits in excess of that. So they purchase reinsurance on their block of business, just like self-funding does. But you don't know that. You get a monthly and annual premium. That's all you know, right? In self-funding, you have both fixed and variable costs, right? And the underwriting profits go to the client. So first, the claims fund, right? That is going to cover all claims up to a certain dollar figure and all claims in the aggregate. Then you're going to purchase what they call stop loss insurance, which is basically a soft pillow around your claims fund that's going to cover all claims past a certain dollar figure and all claims over the aggregate. The next is the administrative fund, all right, which is the cost of kind of operating the self-funded plan. So great year, get a lot of money back. Expected year, get some money back. You go over, you exhaust your claims fund, great. We have protection for that in the stop loss. So what does that look like? If you break it down from a premiums perspective, about 60% of your dollar is going to go into the claim fund. 30% is going to go into the stop loss, with an additional 10% going into administrative fees. So if you did it on $1 million of premium, this is what it would look like. So claims examples. Claim year better than expected. We have a $500,000 claim and a $40,000 spec deductible. In the claim fund, they're going to take the first $40,000 of that claim out of the claim fund. The remaining portion of that $500,000 claim is going to get ceded to the reinsurer, the stop loss carrier. Also, we all have claims, $500,000 of claims in that plan year below the specific. We have $600,000 in our claim fund. We have now a surplus of $100,000. So this program was designed to do exactly that. It was protecting for the catastrophic loss, and it was accumulating all those claims. That's a good year, and you'll have a surplus at the end of the year. But what if you have a bad year? Again, another $500,000 claim. Portion of that gets taken out of the claim fund. The remaining portion gets ceded to the reinsurer. You have now $800,000 of claims below the specific deductible. That overage goes to the aggregate stop loss carrier. So again, you're protected. Any questions on this? Yes, sir.
Who manages the $500,000 client? Is that in their account or is it?
So they have a claims account that they pay into, and then as they're paying into, the TPA is then taking the claims, the money out of the claims fund to pay for the different providers and services.
Like in a money market, bond fund, like some kind of.
No,
It's pure cash.
it's cash. Yeah. Great question. So this is a self-funded client study. We had 115 employees on the plan. They were fully insured. They got a 0% increase. And they were excited that they got a 0% increase. And we stood across the table and said, you're getting screwed right now. They're like, what? They've been conditioned for years that a 0% increase, that's the pinnacle, right? But we're like, no, you're so profitable to them that they're not going to give you an increase. You should go self-funded. So the first year, the claims performed better than they were healthy. They were relatively healthy. Accumulated $163,000 surplus in the first year. Next 48 months in the program, almost another $500,000 of surplus. This was a nonprofit client. They were able to use that money to support their mission. Awesome example. So, yes, great. Mm-hmm. Great question. The answer is yes, right? So within the surplus, you can allocate a portion of that premium to the next year's premium, or you can keep it for what we call a rainy day, right? Because as I mentioned before, 7 or 8 years are going to be really good years, and you'll have a 2 or 3 years that are going to be really poor. And you might see an increase in your premium, but you can utilize the surplus to pay down that increase. You leave it in a fund. Yeah. Greg, you have a question?
What,
He's multitasking back there. He's giving business cards and like it. So.
When I run into clients and they have a 0% increase or up to a single digit increase, is that a home run for you?
100%.
What's the number of automatic cash money back?
If they're getting a single-digit increase, that means that they're performing really well. We anticipate that we would save them a lot of money going into self-funding. Yeah. Correct. Yeah. Thank you. So it's not enough just to create a self-funding structure. You have to then do the hard work. This is where we really get involved with our clients. I know Jeff does this as well with his company, but there's 6 things that I've listed here that companies should think about doing or implement as part of their self-funding strategy. First is pharmacy benefit manager carve out, medical bill reviews, data analytics, high cost claimants, concierge services. I talked to Doug a little bit about that earlier, direct contracting, and then advocacy services. I'm going to go into each of these, in a little bit more detail. So a lot of your costs are going to be in the pharmacy, right? The pharmacy spend. And what you might not know is the manufacturers incentivize the dispensing of their pharmaceuticals, and they provide that in the form of a rebate. And that rebate gets sent to the insurance company. So in a fully insured world, like Aetna is owned by CVS Caremark. So that CVS Caremark is their pharmacy benefit manager. So they get those rebates, they keep those rebates and make a profit on that. Where you can carve what they call carve out. So you're carving the pharmacy benefit management contract out of the network, or the TPA services, and you're going to an independent. Why would you do that? It's misaligned incentives to keep it the other way. This incentivizes them to reduce your healthcare spend. So the rebates can flow back to you, the employer, not to the insurance company. In addition to that, they can also do things such as copay assistance programs, grants, internationally sourcing pharmaceuticals to get to a lower cost. They also can help your plan participants utilize biosimilars versus using the brand names that are ridiculously expensive. So again, an independent pharmacy benefit manager is looking out for you and your employees, not the insurance company. So we do a ton of carving out. And this is an example where 125 on the plan, they made a transition to self-funding. So they were already self-funded, but we wanted to take a look at what the PBM services that they were being provided. It was already carved out, but when we did a reprice, you could see this is what they were paying for pharmacy, and this is now what they're paying on the far right, 227. So we reduced the cost by over 100,000, carved $100,000 out of the plan. If you do anything in self-funding, carving out your pharmacy benefit manager is a must. Next is medical bill reviews. Hospitals, on occasion, will overcharge your employees when they go and get care. Am I right, Jeff? Jeff's laughing. He's like, yeah, imagine that. And guess what? Nobody's checking on them. They're not checking on them. And your employees don't know any better, right? They just go, I can go to the hospital, they get a service, they can pay the bill. And sometimes we've seen them overcharge illegally, because these are all published rates. So they will charge whatever, sometimes they'll charge whatever they want. And without a medical bill review company to audit what they're doing, you might be overpaying for claims that you don't necessarily have to. So this is number 2 that we implement, is we implemented a medical bill service that does an audit of all claims over 25,000. And here's a result of one, where we looked at 6 negotiated claims. They were charged $250,000. It was repriced at $156,000. So $100,000 of savings. Now the medical bill review company takes about 30% of that. But I'm going to ask you the question: Are you glad to pay that 30%? Absolutely, you are. You'll pay that anytime, any day. If they're going to find ways to save you money, you're going to pay for that. Yeah. There's no risk. Yeah. Data transparency, as I mentioned, I'm going to fly through this. You have to know how your plan is being utilized and whether it's being utilized effectively. And if you don't have the data, you're not going to be able to do that. Self-funding provides you all the claims data, and doing regular reviews of your claims data to see, can we change the plan design to reward certain behaviors and maybe punish other behaviors? Are there things that we could be utilizing, such as direct contracting and concierge services, which I'm going to talk about next, to help reduce claims costs or get better healthcare outcomes for our employees? So data analytics is important. And as you can see in this slide, 7 claimants totaling over $1 million, but over, a 5 or 6 year period, $500,000 in surplus. Yes, Doug.
Follow up on Brian's question. How do you feel good about the underwriting from my risk pool and the actuarial plan? How do I know my stop loss?
How do you know whether your stop loss or your underwriting are done right? Well, with self-funding, I would say, to answer that question, I'm going to try to answer the question, but it's competition, right? So you can look at different funding structures, you can look at different third-party administrators of claims to say, am I getting the right price? Am I getting the right services? I would say that's probably how you would judge that over time. And because you know what your claims are, you're going to be able to budget for next year's premium well in advance of the renewal. So in fully insured, you typically get your renewal 60 days out from the renewal date. And it's usually a sledgehammer over the head saying, this is what you're going to be paying. In self-funding, you have an idea of what you're going to be paying typically 3 months after your renewal. So you're now starting to look at, how can I continue to reduce costs within my plan so I can stay within my healthcare budget? Does that make sense? Yes, Brian.
You said earlier in the discussion, 50 employees or 50 insured?
50 insured lives on the plan.
So if you have 25, if you have a business of 25 or 10 employees, but a lot of family members, that could get you to 50?
No, that does not get you to 50.
Okay.
Yeah.
Okay.
Yeah. Yes, sir.
How does it work with HIPAA transparency? If you have 50 employees, you kind of surmise who you employ.
Yeah.
How do you get around that?
Yeah, so the great question. The claims reports are all de-identified, as the employer. So small company, you're going to know somebody's going to have like a serious medical condition, right? Most often, because the close-knit group is going to share that information. So as long as they share it with you, then you're not violating HIPAA. But within the claims data report, it's all de-identified, so you don't really know exactly who those people are. Yes.
So some of these examples you're giving, it sounds like the surplus that's being generated is more than those Obamacare limits, the 15% profit, right?
Yeah.
It is kind of profit.
Yeah,
right? So
you're operating outside of the ACA.
So they must be, they must be treated, there's a carve out of some sort.
Yeah, so you're not, when you're in self-funding, you're not, you don't have to do the medical loss ratio. Great. Any other questions? These are all great questions. So occasionally you're going to have high cost claimants. Now think of it, you have a cancer diagnosis, or somebody that, an employee has a cancer diagnosis. It's going to be highly complicated. They're going to be working with a number of different providers, right? But you need somebody maybe to quarterback that care and work with the different providers to make sure that that person is getting the best healthcare outcome possible. That may mean you want to spend a lot more money up front to get that healthcare outcome to, a positive healthcare outcome. So what we would recommend that you do is hire a concierge service, right? And a lot of the TPAs now have that built in to their program. So when you're going in, they'll get a nurse case manager that's helping that plan participant manage that claim. Because you may have different providers giving different information. and not really coordinating the care. So coordinating the care is really important, and concierge services helps the high cost claimants get to right care, right cost.
Brian,
Yes.
the concierge services outside of a self-funded plan, are those available to like individuals?
Yes. Yeah. So there's a number of different physician practices, mainly in the primary care, that are going into a concierge model where you're paying an annual fee to be for them to be your provider.
Right, I meant more for an episode like cancer diagnosis, you hire
Yeah.
a person who's your advocate for.
Yes. Yeah, you can do that.
Outside of the primary care physician practices that are concierge practices.
Yes, so that's what I was talking about. So the nurse case manager would be the one that's coordinating that care
But you can just hire them as an individual.
as an individual. Yeah, yeah. No worries. Great. So this was an example where we had somebody on the plan that was costing us about $300,000. But what we were able to do was coordinate with a provider to cap those claims cost to 180,000. Right. So we had a concierge service provide that service to get to a provider at a lower cost, still providing a high quality care. Again, a generated savings. So they received a 4.2% decrease the following year being self-funded, and then another 9.2% decrease the next year. So we still have a high cost claimant, but we're utilizing the concierge services to find right care at right cost. Yes, sir.
Did they have to change providers to get into a concierge situation?
They could, yeah, in that regard, they did.
Would they have to though?
Yeah, they would have to in that regard. Yeah, like most people, within specialties aren't really, I would say, loyal, but they are with primary. Direct contracting, this is another service that a lot of companies are starting to utilize. So they want to direct their plan participants to a provider that we have negotiated rates up front with that provider. And the reason why a provider would do that is they know that they're getting all the plan participants. So they're getting guaranteed patients. And we're saying, okay, but if we're going to give you all these patients, you're going to do it at our fee, not a fee that an insurance company may charge. So a lot of companies are starting to utilize direct contracting. And where do we see that? It's usually in surgical or end-stage renal dialysis. So if you're doing direct contracting with surgical, laboratory, or whatever, you can save it on average 5 to 15% on healthcare spend. So if you have a client that has an average annual claim of $2 million, you're saving somewhere in the $100,000 to $300,000 on that claim. Same end-stage renal dialysis, really expensive. But if you can contract with a provider of that, you can reduce that cost significantly. Okay. People get older. As they get older, their healthcare costs continue to go up. Their utilization of healthcare goes up. So you may have people on your plan that are Medicare eligible. The advocacy services is one where they're educating people that are Medicare eligible to look at Medicare as an option versus their employer plan. You can't force them to go to Medicare, right, Jeff? He's laughing. He's like, we should force everybody to go to Medicare. You can't do that. But you can educate them on that, right? Hey, did you know that we have this service, and this service will have you review whether Medicare makes sense for you or not. That's a great idea if you're self-funding, because again, their utilization is most likely going to be higher and their medical costs are going to be higher. Same thing with COBRA. Let somebody go, they select COBRA. Again, they might utilize the plan and they're not even really your employees anymore, right? But can we go to them and say, hey, can we get you into a single plan or a family plan through the ACA? Let's compare and contrast the costs. So we're big believers in advocacy services. Bill.
So in reference to Medicare and the idea that someone should consider going on adverse on the plan, isn't there certain penalties if you don't enter the Medicare time? Does that
No.
matter if you're actually on an older plan?
No, you're not. There's no penalties for not going on. If you have an employer-sponsored health plan, you can be on that.
The out is.
Yeah. Yes, sir. Tom.
Can you incentivize them to go on that?
I don't know, Jeff. I don't think you can, right? Like, yeah, a raise for another reason. Yeah, just like, yeah. I'm like, yeah. You have to be careful. Like, I would just say you have to be careful. Yeah. So this is the potential savings by utilizing the advocacy services. I put this as a bonus slide, so I'm going to talk to my good friend Jeff here, who I said knows a lot about self-funding and health insurance. Reference-based pricing really hasn't caught on here. It's a little scary for people, but it is a great way to reduce claims costs. So you're basically saying to any provider, we are going to pay a certain multiple above the Medicare rates. So somebody goes in, gets healthcare treatment, and then they go to get, the provider goes to get bills the invoice. They're going to, the carrier is going to say, we're only going to pay this. I don't care what you're charging. We're only paying this. So then what happens typically is the provider will then balance bill your employee, which they can't do, but they try to do it anyway and collect from the employee. And that's why reference-based pricing really hasn't taken off, because a lot of employers are like, I don't want that headache, because I know that I'm going to have employees coming to me left and right going, am I going to go into collections? Am I going to go into medical bankruptcy? So the answer is no, they won't, but they just don't want the headache of it. So this is something you could do, but I'm certainly not recommending it. So exhausted all of these, but there's so many more advantages going self-funded than going to fully insured, staying fully insured. It's less risky. There's a number of different platforms out there, whether it be captives, consortiums, standalone self-funding models. There's more competition in the marketplace to go self-funding than there were, say, 10 or 15 years ago. So we have to educate the public on these things and say, there's a better way forward. Yes, sir.
Hey, Brian, is it any more complex to self-fund over basically spread over multiple states versus a single state?
No, it's not complicated at all. Yeah, so certainly you would want to utilize a TPA that has a national platform, but whether it be an Aetna or Cigna or whoever it may be. Yes.
For the reinsurance, is the underwriter reevaluating and re-underwriting that risk each year?
Yeah.
For a number of years?
Yeah.
And then do you ever get to a point where if you have a couple of years of bad claims, the premium increases on the reinsurance outweigh the benefits of the cost increases on the fully insured side?
Great question. So if you go standalone self-funding, that means you can access a number of different reinsurers on any renewal, right? Versus going group self-funding where you're utilizing a captive or a consortium. In standalone self-funding, they could really jack up the rates. They can laser your plan participants out of the program or at a much higher deductible. So laser endorsement is, Phil is a high cost claimant. I had a $50,000 spec deductible for everybody else, but Phil's going to be a $200,000 deductible, right? So in standalone self-funding, that is rare. That risk is really real. In group self-funding, they typically don't laser plan participants going forward basis. You may going in, and usually if you have lasers going in, you don't go in. But let's just say you go in. There's no new any plan participant that has a high cost claim. They're not getting lasered out of the program. Okay. The other thing too is they have rate caps. They negotiated rate caps on the reinsurance. So they go, all right, well, we're going to get a 30% rate cap on the stop loss insurance, which doesn't sound, it sounds like high, right? 30%. But I would say, number one, I would compare that to fully insured. That's certainly going to be like a 60% or 70% increase. In addition to that, you're talking about 30% on 30% of the cost, because 30% of the stop loss premium makes up, so you're like, it's 9% increase. We've conditioned the public that 9% is good, right? So I'll take a 9% increase, and I know why that I'm getting that increase. Yeah.
I'm sorry, the deductible on, I imagine you play around with like a deductible on that to lower your cost of premium. And does that deductible then come out of that basically bucket you have for that claims bucket?
Yeah. Great question. So like, again, that claims fund, you can raise the deductible. A lot of companies start at a lower spec deductible and raise that over time as they get more comfortable assuming risk. As you raise the claim deductible and the aggregate of the claim fund, you lower the cost of reinsurance. Yeah, Mark.
Brian, so I have a couple buddies that each own our own business, and collectively we have 200, 300, 400 employees. Would it make sense to join together and do an analysis and look at?
Unfortunately, you can't do that, particularly in the state of Pennsylvania. That would be called a MIWA. MIWAs are illegal in the state of Pennsylvania to do. So you would have to be a single employer with one FEIN number to do that.
I've had friends in the past, like Hutch, his group, they had thousands of people that they were self-funding.
But if they're in a group self-funded plan, right? So they can.
Multiple companies, and he would take these great vacations every year.
Yeah. So I know what you're talking about. So Hutchinson is in a group captive for their commercial property casualty insurance. That's where they do that. That's where they go on those great trips.
No,
it's not for health insurance. Yeah.
So just in terms of the opportunity for you, or the opportunity for people to talk to you, you put a slide up earlier that talked about the penetration of self-funded insurance plans. It's very high.
Yeah.
It's already very high.
Over 65%. Yeah.
So is there opportunity for you with the people who are already in plans because maybe they're not well designed, or is it really just the people who aren't in yet?
So I had 3 new business meetings yesterday, 2 of which they're already self-funded, but they're not managing their claims because they don't have the risk management strategies in place. So they're looking to hire us to implement these things and stay self-funded in the same platform. So yes, there's opportunity there as well. How am I doing on time? I'm over. Sorry. Yeah, sorry.
Always a sign of good speech.
Yeah, great. Well, thank you guys. Oh, sorry. Go ahead. One more.
You said Pennsylvania, you can't do it. How about if you're in Jersey?
I think MIWAs are I think, yeah. No, it's Maryland that I think it had, allows MIWAs. So possible. So great. Thank you, everyone. Appreciate your time.
Don't forget, the expo is next week. And otherwise, all our board members here, if you are not a member of the BRF, or join us, come find us, we'll get you in. As part of that, but hope to see you guys next week. Thank you. Thank you, Brian.
Hey, good. Yeah. Thank you. Appreciate it. Nice meeting you.
Yeah, absolutely. That was great.
Thank you. Appreciate it. Thank you. I appreciate you. Yeah. Jeff, thanks for the assists.